Welcome, everybody. Big hello from Salt Lake City, Utah, and the University of Utah. We are happy to be with you at 6 o'clock in the evening in the Rocky Mountains. And we're talking about cervical epidural abscesses tonight. The format is going to be similar to what we've done in previous versions of this, and we are honored to be hosting tonight's event from the University of Utah. I will introduce next Brandon Lawrence, my partner and the co-chair of our Spine Fellowship, who will be giving a brief talk about cervical epidural abscess treatment, followed by 3 cases. Peter Shorten, our first fellow, will present a case, and we'll have discussion, followed by Robert Owen, our second fellow, who will also have a case. And then a third case presented by Travis Bailey, our chief resident going into spine surgery and doing a fellowship next year at Emory. And hopefully we'll have some good conversation during and following each of the cases. Our 2 other partners here at the University of Utah, Ryan Spiker and Nick Spina, will be helping Brandon and I answer questions that come up. Please use the chat box on the right corner of the screen to ask questions or make comments, and we'll follow up with those. And with that, I think we'll get started. We can hand the controls over to Dr. Lawrence, and he can start with a presentation. Thank you, Brendan.
All right, guys. Well, welcome everyone. Thanks for joining in on another one of these controversies in spine surgery. Tonight we are going to be focusing mostly on cervical epidural abscesses and talking about some of the nuances and some of the challenges with these, as well as hopefully showing some cases that will bring up some controversial topics and ideas from the panel here. So looking forward to a lively discussion. And so let's start out with this hopefully 10 to 12 minute talk just to introduce the topic and on the treatment or the current sort of strategies for cervical epidural abscesses. When we talk about the treatment of cervical epidural abscesses, you know, as most of us on the line here know, you know, the incidence of these is relatively low. Cervical involvement is the least when we talk about spine involvement in regard to comparisons with the lumbar and thoracic spine, with lumbar being the highest. Unfortunately, with cervical epidural abscesses, these are often associated with far worse outcomes, just secondary to it being at cord level and the drastic changes or consequences that an epidural abscess can have at the cervical cord level with neurologic dysfunction. And the most common presenting complaint, whether it's in the cervical spine or other thoracic or lumbar, typically is just this dramatic and acute increase in neck pain and or back pain. And like I said earlier, the worst outcomes are often associated with you know, neurologic impairment. And so that's when things start to get a little bit testy in regard to some of the things that we will discuss, and some of the options for, you know, operative and non-operative treatments. And so when we look at cervical epidural abscesses, you know, 45 to 77% of patients will have neurologic impairment. And we think that a lot of the neurologic impairment sometimes isn't always necessarily from direct cord compression, but actually is secondary to the vascular changes that can occur in this intense inflammatory environment. And a lot of it can be, you know, venous outflow issues, and sometimes even some arterial inflow issues. And so that's a lot of the issues that can come up with these epidural abscesses, and it being more of a vascular origin, but also compressive. And there's a couple cases here that will kind of illustrate that. When we talk about risk factors, IV drug use is probably the most common presenting risk factor that we see with these epidural abscesses. but then other ones just being immunocompromised, secondary to medications and or diabetes. We do see this higher in the older population as you get over 50, obesity, underlying malignancies, and then also some of the other things that can cause other comorbidities like chronic liver or kidney diseases, but then also prior neck radiation and things like that, and then also pharyngeal abscesses, that are outside the spine can enter within and cause epidural abscess. When we talk about the workup of these, obviously a thorough history and physical. The biggest thing that can cause patient stress is just their hemodynamic status. If they're septic, then they're going to be in a much different situation than if they come in not fully septic. Obviously, white count will help guide treatment, as does ESR and CRP. Blood cultures are very important early on. Hopefully, blood cultures are drawn prior to antibiotics given. But if their hemodynamic status is poor, oftentimes antibiotics are given very early on, and they may already be given by the time any spine consults are completed. The second part to this is complete neuroaxial imaging. Secondary to the Batson's plexus and the valvulus veins. These epidural abscesses have the tendency to travel. And so if there's an epidural abscess in the cervical spine, you just have to make sure that there's not one also present in either the thoracic or lumbar. And then finally, the transesophageal echocardiograms are really important as well, just to make sure that there's not already valvular vegetations, which can further complicate the situation. When we talk about some of the causative organisms, the most common is by far Staph aureus. Nearly 75% of these epidural abscesses will be Staph aureus, and half of these will be the resistant form. We also have to be careful, especially in the IV drug users, of Staph epidermidis, and then the other types like E. coli, Pseudomonas, and Proteus. We can also see the gram negatives. The more more difficult one to treat often is Pseudomonas in these heroin users or IV drug users. And it's also important to know that these can spread through a variety of mechanisms, both direct and indirect, and they're typically hematogenously spread. And so all of these factors and things are important in the initial workup. When we talk about getting into treatment, number one is you need a definitive diagnosis, and blood cultures often are helpful. If you can get blood cultures that grow a certain type of cocci, whether it's gram positive or negative, and you can start to tailor antibiotics pretty early on, but you need to wait until you get your definitive diagnosis to really treat the patient and know that antibiotics for these problems, even though surgery may be needed, that antibiotics are the mainstay of treatment. And if you're not on the right antibiotic, the risk of failure is very high. So when we talk about surgery, and really that's why we're here, is the issue surrounding surgery is, if surgery is needed, what do you do? And when do you do it? And we'll go into some of the literature behind some of this just to kind of help guide all the fellows out there as they're getting ready to enter into practice. This is something you will see, and hopefully this will help you guys make quick decisions. And so when we talk about spinal epidural abscesses, Jens Chapman wrote this article, and it's a great article talking about spinal epidural abscess and risk factors, medical versus surgical management, and helping guide you whether what risk factors to look for to help guide operative versus non-operative treatment. And they looked at 128 patients, 79 male and 49 female, with a mean age of 53 years old. They did have a good follow-up for epidural abscesses, which was 241 days. And they looked at essentially three groups. One was antibiotics alone versus surgery. And then finally, this failed group, this group of medically treated patients that had failed treatment and further went on to surgery. And that's how they came up with some of the risk factors that we at the University of Utah use quite a bit to help us determine operative versus non-operative treatment. And so when we look at this is slowing down a little bit here. So when we look at this, these three groups, the presenting chief complaint, like I talked about earlier, was site-specific pain, whether it be neck pain or back pain. They looked at also subjective fevers that patients had, as well as the presence of neurologic dysfunction and weakness, and 47% of these patients had this. Some of the risk factors that they looked at were IV drug use, diabetes, and then interestingly, almost 25% of these patients didn't have any risk factors. When we look also at some of the other things that will determine what kind of surgery we do, in looking at the osteomyelitis and the discitis aspects of these epidural abscesses, you can see that that even though it's not highly prevalent from a risk factor standpoint, osteomyelitis and discitis is something that also is often goes along with these epidural abscesses. And that's what, when we talk about instrumentation and non-instrumented surgery, which we'll get to in a minute, that's when those kinds of things play a role. The types of bacteria that we see, they had a nice breakdown. And as you can see, 70% of these patients were Staph aureus, with a smaller percentage of some of the other bacteria that are commonly found as well. And when we look at these three different groups, what you can see is 51 patients initially were treated with antibiotics alone, 77 patients had surgery, and then 21 of those patients that had failed in the antibiotic group. You can see looking at their motor scores. Obviously, the patients, there's a lot of selection bias here. Obviously, the patients who were treated with antibiotics alone had very high motor scores, 96, so they did not have much neurologic dysfunction in comparison to the surgical group, which had lower motor scores, the pre-op score of 80, and then post-surgery, their scores were significantly improved up to close to 90. Now, the problem with these failed groups is these failed patients, and this is the thing that we all are always very weary of, is if you're going to try to treat a patient non-operatively, what tends to happen is they're doing well until they're not. And what you can see is that those patients that had failed initially, they were very high motor scores, but then they dropped significantly. And when they dropped significantly, that was when they likely went on to surgery. And the problem with the later or delayed surgery is that they never really recovered a good motor score. Their motor score of 85, which you can see now with this red box, wasn't as high as the patients that had gotten treated early. And so that's a lot of the reason as to why, when we see these cord level epidural abscesses, we all get quite antsy about them, and often we'll operate on these patients sooner than later. When we talk about the predictors of failure now, this is I think where this paper gets really interesting, is when they looked at the predictors of failure, they looked at diabetes, the CRP of greater than 115, a white count greater than 12.5, and positive blood cultures. And when you look at the number of risk factors that are present, if none of these risk factors are present, there's an 8% chance of failure. But as you go up higher in the number of risk factors that are present, obviously the likelihood of failure increases, and it will help quite a bit in if the patient's on the fence in regard to operative versus non-operative treatment. I feel like looking at these risk factors often helps us make decisions quickly as to what the right thing is for the patient. And so as you can see, as you get up higher, it's almost 80% failure. So with this particular paper, some of the conclusions were early surgery improves neurologic outcomes with when you compare it to delayed surgical treatment. And if you're going to try to treat a spinal epidural abscess at cord level medically, you really have to be able to follow them closely and make sure you can trust the patient that they'll follow up as well. On to the next paper, when we talk about some of the differences between looking at surgical treatment strategies. This paper looked at 738 patients, and they looked at whether or not, if you did a non-fusion versus fusion surgery to treat these patients, did it matter? What they found was that the fusion population did have baseline worse health at the start. They also found that there was a greater return of patients to the operating room if a fusion was performed, likely secondary to them just being in worse preoperative condition, and that patients who had fusions had significantly greater rates of blood transfusion. That's secondary likely just to the invasiveness of the procedure. With that said, persistent infection, which was common in both populations, was the most common reason for reoperation. And so in conclusion, both laminectomy and laminectomy with fusion effectively treat spinal epidural abscesses. And in patients where you can get away with just a laminectomy surgery, it's okay to do. But those patients that really need that extra stability, and it's important to recognize that stability is a very important part of treating these infections, that also instrumentation should be used. So really, this paper gives you the ability to tailor your treatment, and it's really those patients that have the bony involvement where the instability portion of the infection where instrumentation is needed. This next paper talks about the timing in the surgical evacuation, and this is another very interesting paper looking at this. And so this was a cohort of 87 patients, 62 male and 25 female. 54 of these patients received surgery within 24 hours. 85% had a neurodeficit on admission versus 33 patients who underwent surgery later than 24 hours. You can see they had less of these patients had neurodeficits preoperatively, and these patients were also a little bit older. Maybe the delay to the operating room just needed to, these patients needed to be more medically optimized. But with that said, when we look at the outcomes of these patients, what you can see in the patients in this top graph, the patients that had surgery in less than 24 hours, tended to do a little bit better. So this patient group, Asia A presenting, 3 of those patients were presented as Asia A, and 1 of them actually had a complete neurologic recovery. When we look at the Bs, 5 patients, this group of patients, 4 out of 5 of these patients ended up having at least a 1 grade increase in their Asia scale, which from B to C, which is quite a dramatic improvement. In the Asia C group, in the next group, 9 of these patients, 7 of them went from C to D. Asia D's, 26 patients in this cohort, half of them had a complete neurologic recovery, and then the Asia E's, all of them stayed the same. They didn't worsen. When we looked at the next group, the group that had surgery in greater than 24 hours, what you can see here, the Asia A's, then none of them improved at all. In the Asia B class, there was 1 patient that in the B group that did have improvement, which is also good. It's when we get into the Asia C's and the D's where we start to see some changes and less improvement in these patients. So only 1 of these patients had an improvement in C. And in D, in this group, interestingly, 4 patients actually got worse. And that's what we're really trying to obviously mitigate. And this paper was kind of illustrated that nicely. And so in conclusion, when we talk about cervical epidural abscesses, they're challenging. They're hard patients to treat. I will say that for us, when we decide to do surgery, we treat them emergently. I think as soon as you make that decision, these patients should be treated sooner than later. If you're going to try to treat these patients non-operatively, you have to very carefully select these patients, trust the patients, make sure that their neurologic impairment is minimal to start and stays that way and hopefully improves. The other caveat to that too is to make sure that you have the perfect speciation of the bacteria and make sure that you're treating them with the correct antibiotics. And in these patients that you're going to operate on, if you need stability, make sure you get it. these patients won't do well without stability. You won't be able to treat their infection effectively. And remember that antibiotics are the mainstay of treatment. Again, you have to make sure that you're giving them the right antibiotics. And so that's the end of this portion. And so I think we can go on to our cases now, and hopefully we can illustrate some of these points with some of these cases that we have.
That's great, Brandon. There's been a little bit of an ongoing conversation on the side while you've been talking. Jens brought up a question, and maybe worth just a quick discussion. We talked about risk factors a bit, and we're trying to understand maybe a little bit more of the value of the risk factors in surgical decision making. And what about a patient that doesn't have risk factors? Have we seen infections, epidural abscesses in patients that don't have any of those risk factors?
Absolutely. I mean, I think that one paper showed 25% of patients presented with epidural abscesses without any real known risk factors, and that's when it gets hard in trying to figure out why or how it happened. And so it's absolutely true that patients will present with no risk factors and just have a random epidural abscess.
Great.
Maybe I could add to that as well. That's a really important point. A good number of patients present without a known risk factor. Having said that, looking at the organism involved can be really important. And specifically, we showed that patients with enterococcal infections and some gram-negative infections, even if we don't identify a risk factor, oftentimes there is some reason for that, either an immunosuppression that wasn't otherwise recognized, or in some cases, a colonic cancer. So some of these patients with gram-negative infections, even if they don't have a recognized risk factor, that's something we've got to be very suspicious of something else going on.
They got bacteremic somehow with their GI cancer.
Exactly.
Yeah, super topic. This is Jens. Thank you for discussing this. And I want to echo what Sig said. For me, it's been fascinating to see some patients who fall out of the traditional risk categories. And bingo to what Sig said, they have something else. They have some bizarre dermatologic disorder. They're on an anti-TNF medication for psoriasis or something like that. So I find it actually quite fascinating to try to identify what that portal was. What I am cursed with here are people with really bad teeth. And that's another portal with all sorts of bizarre microbiologic things that leads me to the internet to search. But had it not been for my steady dose of epidural abscess patients during the COVID period, I would have had probably far less to do. But thanks to them, I had an almost daily surgical practice with epidural abscesses. I don't know how this feels, but they were a steady source of additional activities. Thanks.
Well, that is a great introduction. Why don't we move into the cases? And I'm going to hand the mic over to Peter Shorten. Peter's one of our two fellows here at the University of Utah. He was trained in the University of Vermont prior to coming here, and we move into Colorado when he's done. And Peter, from there, please take it over.
Great. Thanks, everyone. Thanks for having us. My first case here.
Oh, you just muted yourself. There you go.
Yeah, my case here is one that we did a few months ago and will stick with me. It may not be as controversial, but I think it highlights how sick some of these patients really can be. So this is a 60-year-old guy who was admitted to an outside hospital. He was from the MICU or transferred directly to our MICU on a Sunday, it was. And he was a diabetic, and he was a poor historian, missed 2 dialysis appointments, and ultimately showed up at this outside hospital septic. And he was started on pressors and antibiotics and had some positive blood cultures at the outside hospital, positive for MSSA, had some cardiac stuff going on. Really his only complaint, though, was some neck pain that was a bit worse than what it has been in the past. And he had some chronic neck pain. And he also had some vague sort of myelopathic signs and symptoms, but he had never sought treatment for it. Now, granted, he wasn't a very reliable patient, but nothing dramatic brought him in other than that neck pain and this sort of illness. He's got an extensive past medical history, as you can see here: end-stage renal disease, CAD, heart failure, AFib, COPD, type 2 diabetes, and he had used meth. He didn't admit to IV drug use, but smoked it. And his past surgical history, he had a simultaneous pancreatic and kidneys transplant in 2011 that had failed. So he wasn't immunocompromised, even though they said that he was on some of these immunosuppressant medications. I think it's fair to say that he wasn't taking any of these at any time leading up to this. We didn't have any labs in our system that is ESR or CRP. His white count when he came in was 8, and his blood cultures were positive for MSSA. And as I sort of alluded to, he was admitted to the MICU, so he was on pressors when he came in and was bacteremic. It really, his only weakness was in his upper extremities: grip weakness, wrist flexion extension, and some hyperreflexia and positive Hoffman's. But these, unclear if they were at his baseline or not, but he wasn't dramatically different than what his baseline probably was. On his imaging, actually at the outside hospital, all we had was this particular MRI, just of the C-spine, and sort of walking through here at C3-4, he's got more degenerative changes, but severe stenosis at that particular level. And as we creep down the cervical spine at 5-6, you can start getting some semblance of some ventral epidural abscess. You can barely appreciate it here. And you can start seeing it right here at C6-7. So when he came in, he was sent with an MRI, with this cervical MRI, and saying that he had a ventral epidural abscess. But you can see as it extends down here, the axial cuts don't catch it. But you can see there's something certainly suspicious going on lower down. And ignore this on the right-hand side. This is his thoracic MRI, and you can see this extensive ventral epidural abscess that just almost balloons as it comes into the thoracic spine, which wasn't quite as impressive up in the cervical spine. Here's some representative cuts. I know it's a lot, but you can see here at T1, this ventral epidural abscess, and it just keeps getting larger at 2-3, at 3-4, and at 4 in particular on the right-hand side, just quite a large abscess there that's pushing the cord off to the left. And then it sort of dissipates as it goes down into T4, 5, and 5, 6. So what we've got here is a very sick man who's got an epidural abscess from C4 to T6. He also has that severe stenosis, if you recall here, at 3-4, that's causing severe central stenosis, as well as a little bit at 4-5, not nearly as much, but and I don't know if I want to go back and if you, Dr. Lawrence or Dr. Brodke, do you want to bring up a conversation at this point before we talk about what we did? This maybe isn't as controversial, a little more straightforward in a very sick guy.
In the thoracic T2, it looks like one of the discs has bright signals. Does he have discitis at one of the levels as well?
That's a good question. Not so much at T2, but certainly down here at like T5, 6, we thought that was something. And on the stir at one of those levels, it did look like perhaps that could have been the nidus of it. And maybe it tracked up almost like here at 5, 6, and because that really is the worst of it. And I don't know if it tracked upwards. There was, I think, a component of that though. Dr. Lawrence or Dr. Brodke, anything else?
Yeah, I think we should stop and talk. Yeah, I'd love to get some input from some of the panelists. Just generally approach to a long, multi-segment epidural abscess, not knowing if you can get it all by draining in skip spaces. I guess, is there anybody who wouldn't operate on this at this point? got minimal neurologic, some neurologic, but minimal neurologic dysfunction, but a very concerning MRI. And then if no, are you approaching this dorsally and how? Or ventrally in the cervical spine and dorsally in the thoracic? I think that's some of the questions, Jack, that you asked. Do you have any answers to any of your questions?
No, Daryl. If you knew that it was a liquid abscess and you could clean them out anteriorly and get good drainage, you'd be a superstar. But you give up the ability to be extensile when you go anterior. But otherwise, you're looking at unzipping this guy by a lot of levels. But I'll certainly defer to Jens and you guys who see a lot more of this than we do.
Daryl.
Yes.
When you approach this posteriorly, and I agree that this was so massive anteriorly, it would be hard, and especially in the upper thoracic. So what's the strategy you use to drain it? Because you can see that you don't want to certainly move the cord. Are you just irrigating out, using your little micro dissectors just to sort of break up any adhesions, sneaking around the side of the cord?
Yeah, that's an excellent point. So I'm just going to reiterate Dr. Geyer's question, because you can't retract anything here. It's working around the cord to a near straight, especially at like T23, near straight ventral abscess. And it helps very little to just do a laminectomy. You really need to make sure that the fluid ventral to the cord is drained, because that's the compressive structure. You can see, particularly on that T23 image, where you've got this pressure straight dorsally from a ventral abscess. And yes, we use nerve hooks and reach around. Sometimes that's not enough. Sometimes we have to do a bit more if it's phlegmonous, which means really taking down a pedicle intermittently and trying to sort of work between segments. But there's no retraction really.
This is Jens. So just for me, group question is, for me, the preoperative differentiation of liquid pus versus a phlegmon is a really big deal, because if you have a liquid abscess, you can just do a couple of little pinhole laminotomies and use a pediatric catheter and wash it out pretty well together with the long malleable nerve hooks on a microscope. If it's a phlegmon, it actually becomes a formal dissection, and you want to try to eradicate that necrotic segment. And then the final point to Jack's question before online is, and you raised that in this case, if there's a discitis, I've seen these serve like a hydraulic pump, which more or less pumps pus into the epidural space. So it's not a true epidural abscess, it's actually an occult discitis. So question to the panel, how much can you predict liquid versus organized pus that requires an active dissection? Thanks.
Yeah, Jens, I think that's a great question. I think I wish I could figure that out. I wish I could look at the imaging and somehow see a characteristic where I say, oh man, that looks liquid, or that looks like phlegmon. I don't have a great way of making that determination. I don't know if anybody else does. I guess sometimes the acuity of it sometimes is helpful. His white count is still on the low side. He's septic though. He's got a huge epidural abscess that's over multiple levels. Yeah, I don't have a great answer for that.
Brandon, what percent would you say are the phlegmon, and what percent are the more liquid abscesses?
I don't even know if I don't even know if I can say percentage wise. It seems like somebody who's been sort of dealing with, like if they've had neck pain or mid back pain for a couple of weeks, I'm more suspicious that it's going to be phlegmon versus somebody who says, it's just 2 days ago, and then now I got feverish, and then they get sick quickly. I feel like the sort of the timeline is helpful. But even in that setting, sometimes you're surprised. You think it's going to be liquid, and it ends up being phlegmon.
Somebody in the chat asked whether or not a contrast MRI scanner would be helpful.
I certainly don't know in this case. I don't think I recall this case very well, because I was sitting waiting for this at like 10 o'clock at night on a Sunday. And given all of his other medical stuff going on, including his end-stage renal disease and the fact that he had missed multiple dialysis, I know we didn't give him contrast. It was really to get, in this particular case, to get as much information as we could to see how extensive this was, given that it just kept getting bigger and bigger on the sagittal C-spine MRI. We were curious if, how far we had to take this. But I certainly don't know if a post-contrast would have changed, our understanding of whether this was going to be just a big phlegmon or if this was going to be something more liquidy.
Nick Spinal made the point. He said that on the contrast enhancement, when you see more rim enhancements rather than the spread of contrast, that actually can be really useful. And I agree with his point about that rim enhancement maybe being suggestive of a phlegmon.
But if you've got a real sick guy like this and you've made the decision to take him to surgery, I think you're committed to do this posteriorly and explore all those levels and clean them out. You have one good shot to try to save this guy, because a healthy person will decompensate really, really fast with this kind of disease. But a guy who's already hanging on by a thread medically, I think you just have one shot to do it, and I think you'd be committed posteriorly. But I'm interested to see what you did.
Yeah, I agree with that too. And I think if you do encounter phlegmon, you just have to be prepared to do maybe some transpedicular decompressions to make sure that you can kind of sneak around the side of that cord to try to decompress as well as you can.
Brandon, one of the papers you presented was a really good one about the idea of doing a fusion, and adding instrumentation almost doubles the chances of a return to the OR. And I think that's an important thing to consider. Having said that, I also think it's important to recognize where a laminectomy might work well and where it would not. So, for example, in a lumbar spine, certainly for lumbar epidural abscess, I think doing a laminectomy can work very effectively. Whereas in the cervical spine, I think I'd be much more likely to add instrumentation there. And to that end, I think making that distinction between where a laminectomy would work well, because that paper just talked about laminectomy in general. I think the region makes a difference.
100%. Yeah. And mid-thoracic spine, you might get away with a laminectomy or something like that as well, or skip laminectomies, things like that are really useful in that setting. But I agree, laminectomy in the cervical spine, is pretty rare that I would consider that.
Yeah, or across the cervical thoracic junction.
Exactly. Like this case in particular, it's like the perfect case to try to figure out what you can get away with and what you can't. And unfortunately, yeah, Pete, let's go on and we'll show everyone what was done.
Yeah, I think that I appreciate that conversation, because if I can, divulge, this was Dr. Spina and my case from a month or so ago, and we had all those same conversations. You can't predict, is it a phlegmon, is it not? And you go in, and this guy, he literally is hanging on by a thread, and so you've got one chance to do this. And so this is what we booked him for. We planned to address, but we didn't talk about whether anyone would address that really stenotic area at C3-4. And we decided we're going to do it. I don't know how much of his signs and symptoms were related to that versus everything else. Very small thing, though, to just do a little laminectomy up there. So we decided to extend our decompression up to C3, and then essentially go do the entire C-spine, and then where he was super tight from 2 to 5, if you recall, just right through here, and plan to go in where it's really big right here on the right-hand side. In cases of phlegmon, do a right-sided transpedicular corpectomy and try to reach around right through here and get that, and then essentially instrument all of it. And when we got in there, it was really interesting. We got up to C2. We can do this. I mean, we don't need to talk about this or dwell on this, but we knew this guy was going to fail from the get-go. All right. But when we got up here on the left-hand side in particular, right up at C2, it was really interesting. There was, if you recall, there was no pus up there on the CT scan or on the MRI. And I remember Dr. Spina, kind of getting into this C2-3 facet and just pus pouring out. And like I've never seen it in the spine before. I've seen it in other joints, but and it just kept coming and coming. And that was what it was. It was just this liquid pus, and as we sort of evacuated up here, and did our laminectomies, and then as we got down to the thoracic spine and started doing our decompression there, we did exactly as Dr. Broadkey mentioned earlier. We ended up not having to do the right-sided transpedicular because it was so liquid. We got a nerve hook around and wrapped around ventrally and just sort of evacuated everything. And it was very liquid. It all came. And so we had a little pediatric catheter and ended up irrigating that throughout. And at the end of it, I think it was, it ended up being 5 or 6 hours or so when it was all said and done. There was no more pus coming out. We sort of evacuated everything that we possibly could and felt that there was no more it was certainly not a phlegmon in there. Unfortunately, the guy did very poorly, as you might predict, but this is what we ended up doing surgically, and curious to hear if anyone would do anything differently or if any other thoughts.
Pete, there was a question, and sorry, by the way, I cut out before my internet went down, and apologize mid-comments, but there's a question about the discitis specifically. Did you do anything separate from your treatment of the epidural hematoma, or I'm sorry, epidural abscess with the discitis?
You know what we did, Dr. Brocky? We were debating whether or not to take our decompression down essentially to this far, to include this 5-6 disc space. And we did. That's what changed our mind, essentially, was this imaging. And that's really, it was largely because of every time we stuck the probe in and tried to evacuate a little bit more just kept coming. And so we took a little bit more of, the 5 lamina, and we just kept working south. And so we didn't go in, we thought about it, but we didn't go in necessarily thinking that we were going to do some decompression to address that specifically. But by addressing some of this more prominent phlegmon, whatever pus, more cranially, it just kept working down naturally, if you would. But beyond that, we didn't do anything specifically to address that.
Peter, if I can just ask a quick question. You mentioned that he did poorly. Can you define that for us? And then add on to that, at what point do you say go, no go with somebody this sick? This becomes almost like the palliative argument with oncologic cases.
That's a super question. The circumstances of this being that he came in when he did, a Sunday afternoon, we had no contact. The guy was able to participate in an exam, early evening, and you could just see him deteriorate. And I remember I examined him before the MRI, and I examined him afterwards. And the exam was very different, just his ability to participate. And having conversations with the family, I think, is important. This guy came from Montana, from 6 hours away. Your question of a no-go certainly is appropriate in a guy this sick. He did poorly in the sense that he ultimately died from a withdrawal of care 5 or 6 days after the fact. He had if you notice on the slide, there was some concern. He had AFib with RVR at the outside hospital with concern for an NSTEMI, and he had another concern for an NSTEMI, and ultimately, pretty conclusive 2 days later. He was able to wake up and participate, but we were never able to extubate him. And then his kidney shut down. Then he ultimately went into end-stage renal failure from sepsis, is what it was. And the family withdrew care, 5 or 6 days after that.
So I think the issue maybe, just sorry to talk over you. If you're not finished, please.
No. Go ahead, Dr. Brocky.
I was just going to say, to Izzy's point, the issue I think really is, are you ready to have a sort of a goals of care discussion with the patient and family when they first arrive, and potentially talk about hospice? Because that's what you're really talking about when you're talking about a no-go. Somebody brought up, well, if they're paraplegic, is that a no-go?
Yeah.
But it's not just the neurologic issues. It's also that that they will succumb to the infection potentially without managing this. And so you're really talking about, are we bringing in the goals of care team and having that discussion about hospice care? And a lot of times the patient's not ready to manage that discussion. And then you have to make a decision thinking that you probably will have that discussion, but the patient's not ready to have that discussion the night that you're having to deal with this. And so you may have to do the first part of this surgery because they're not ready to have that discussion yet. At least that's been my experience. I don't know if others have thoughts on it. It's an important question, I think.
You're totally right, Dr. Brockian. And I honestly think that if circumstances were different, we started this case at 2 in the morning. I mean, the patient rolled into the OR at 1:30 in the morning, Monday morning. You know, like it was from the MRI upstairs. There's no way we can contact his family. You know, the guy can't give us any more information because he's septic and delirious. It was really sort of the worst possible case to try to have. But I think if it happened,
Nick had said that you even had a bit of that discussion that night, and the family still wanted to really be quite aggressive, which is not uncommon early in the process where they don't realize as much as we realize.
Yeah, when
you try to educate, but it's hard in the evening, on the weekend, in the sort of the throes of the beginning of the end.
But Daryl, you know, when he's decompensating on 2 serial exams, you're stuck. You know, there's not a lot else you can do. So, you know, you guys were pretty heroic. You did the right thing. It's just unfortunate, the other circumstances.
The only other thing that you said, it was liquid, right? So when you went in and saw it was liquid, could you have done multiple laminotomies, put a pigtail catheter in, and just irrigated the whole thing out? That way, avoid the instrumentation and probably done a smaller procedure. I'm not sure it would make a difference, but you could have probably got it out, right?
Probably. Where to stop and where to begin, and you know, I guess that's the question, right? It is liquid, and this liquid is coming from the C2-3 facet, which, if you recall, looking back here, you know, there's nothing up here at C2-3, right? So it's we were there questioning, is the pus that's coming from the left 2-3 facet joint, like as his head is down, right? We've got him in a Mayfield, or we got him in tongs, and his you know, body habit is his head's positioned down, and so gravity's taking effect. Is it the pus that's coming from down here and extruding through there? I mean, your point is well taken. Could we have done something less and had a less invasive sort of procedure? I doubt that his outcome would have been dramatically different, but certainly the stress on his body and the stress that we imposed would have been totally different. I just think that you're going to be left with that question: did we get it? You know, is the pus up here?
Well, and to point, you know, to do a laminectomy or even multi-level laminotomies in the cervical and/or cervicothoracic junction can be quite dangerous as well if you're not going to instrument. The other issue is that you've got an osteomyelitis and discitis, and oftentimes if you don't gain stability in that setting, you can also run into trouble later on. So even though I love all of these different ideas and options, same patient, another day, I'd probably do the same thing.
Hey, Brandon, somebody asked about interventional radiology. You think there's a place for that?
In this kind of situation and setting, I would not defer to them or rely on them to try to deal with an issue like this.
They're super tentative to try and squeeze between a stick cord and a ventral abscess. It's just, it's really, I think, a surgical treatment.
Yeah, would there be any type of abscess?
And manage the infection, stabilize the spine, and get out. And that's the question. Oh, sure. Yeah, no, there are lots of abscesses related to the spine, paraspinous abscesses. Even a dorsal abscess can sometimes, depending on size, particularly in the lumbar spine. But some of those don't need to be treated. But I think that's a great point. it should be coming to mind to at least ask. Why don't we have two more cases, not sure we'll get through them, but let's move on to the second case. At least we can continue this conversation while, during and after that case as well. So Bob Owen, our second fellow who joined us from WashU and is heading to Atlanta next year, has a case equally as interesting for different reasons. Bob, I don't know if you're muted. I can't hear you. Yeah, thank you. Bob, I think you're muted still. There you go.
Is it coming?
We haven't had this in a long time.
No.
Yes, I can hear you now.
Got it. Thanks so much, Dr. Brodke, and to all the panelists for their comments. This is a very different case. This patient came in with just worsening baseline neck pain. He's a 64-year-old veteran with kind of slowly increasing neck and new left shoulder. There's no weakness, no concerning recent history of infection. Couldn't be more different from the last patient, healthy, and most notably not diabetic, not immunocompromised, no history of HIV, no recent travel, no history of IV drug use. On his exam, he is completely hemodynamically stable with normal motor exam, bilateral upper and lower extremities, but with pain and a very distinct sort of C5 radicular distribution on the left, with some paresthesias there. Otherwise, normal sensation, no upper motor neuron signs. Labs, very borderline elevated white count with an elevated ESR and CRP, and notably MSSA on his blood cultures when he came. And so this is just representative imaging after his workup at the C4-5 level, showing this dorsally based left-sided epidural abscess that you can appreciate here, creating some sort of asymmetric moderate stenosis. And this is better appreciated on, he was able to have a gadolinium scan, and you can see here the rim enhancement of this lesion, which was talked about a little bit in the last talk, but again, helps you better appreciate the size of this, especially on the sagittal cut. And so again, this is a much simpler presentation, very different. This is essentially a healthy 64-year-old with a isolated C4-5 epidural abscess, and outside of some paresthesias, a normal exam, and he's clinically stable. And I don't know if we are doing the polling or not. We can also just open this up for any discussion points before we move on and talk about what we did.
Yeah, maybe I'll just ask a couple of panelist questions and then we can move on. Izzy, comments on?
Sorry, Daryl, you cut out. I didn't hear the actual question.
I was just, sorry about that. I was just saying this is really different than the first case, as Bob mentioned, and I just get your initial thoughts on a rather more healthy patient with a focal dorsal epidural abscess in the cervical spine without neurologic injury or loss.
Yeah, this is one that I would watch very, very closely initially before rushing him to the operating room. Complete the workup as much as we can, get him on the right antibiotics, and persist. If there's any hint that he's deteriorating, becoming septic, or progressive neurologic deficit, then yeah, I'd do a focal laminotomy and decompress that area because it is well circumscribed. But I wouldn't rush him to the operating room that night, that day. I'd probably watch him a little bit first.
Sig, anything?
I agree. This is a very, very different presentation. Having said, I think the big difference is obviously the anterior versus posterior circulation of the spinal cord. And so anything ventral, I'm much more concerned about than dorsal. This does seem to be a bit loculated. Again, when you see that rim enhancement with a central abscess, I do tend to think that that might not be something that would be quite as responsive to antibiotics, but I think this is something which is a minimal laminar foraminotomy. You could decompress this. I think looking at the whole neural axis is important here. I wouldn't think that something that this isolated would cause such a remarkable elevation in a SED rate, CRP. So I'd certainly look for other sources. And if this were truly the only source, I think not in the middle of the night, but I think at some point within 24 hours, I'd probably do a laminar foraminotomy, decompress this, and get it taken care of. But much less urgency when it's dorsal than ventral.
So we've got a non-op with close observation, maybe a slow move to the OR, and then Jens, just based on comments that I've been reading you writing, it seems like that's not your approach. You would much rather go cervical spine, epidural abscess, operative case. Is that accurate?
Correct. Yeah, I don't want to belittle, but again, in our experience, cervical and thoracic ones, when they go sour, it's usually in the middle of the night with inconsistent nursing notes, a lot of confusion, or on a holiday weekend. So I just like to take care of them. This is a very nice little case, just like Sig said, a small foraminotomy, hemilaminotomy, not even hardware. First case next morning, and you can rest easily. And again, as always, I'd get a pan neural axis MRI scan to make sure there's nothing else. Thanks.
All right, Bob, why don't we move to the answer that?
Okay, and to bring up from Dr. Lawrence's talk earlier, this patient had one risk factor, according to the paper from the Spine Journal in 2014, putting him a risk factor percent of failure around 35%. And this patient was very reliable, very reasonable person, easily monitored. And so the decision was made to pursue non-operative management with IV antibiotics, culture specific, after the completion of his workup, and with the understanding and with very clear discussion with the patient and the team that he'd be undergoing very close clinical and imaging monitoring. And I'll just bring up, this is a repeat MRI at the same level 2 weeks later, really showing excellent improvement of that abscess. It's really even hard to appreciate where it was. And so I think this can be seen as a big success for this patient, and just a contrasting point to everything that occurred in the first case. But all the points are certainly well taken, especially after the talk Dr. Lawrence gave about the high risk of observing these. If they go on to fail, they don't do well. And so I thought this was a very interesting case and one that we haven't seen many like.
Thanks, Bob. That was a great presentation. Just a few. One other comment that I was going to bring out. Somebody, Navito, brought up the rim enhancement suggests the need for posterior surgery. I guess because there's a question of whether it's walled off, and your presentation showed that that this can actually still be treated well with systemic antibiotics, but with some risk and close observation, exactly as Izzy mentioned. I'm going to stop now and let Travis move on to at least show the last case. You can go all the way through, Travis, from beginning to end. Travis Bailey is our chief resident going into spine, doing his fellowship next year at Emory. And we'll just run through this last case, and then we can have a little discussion if there's still time. Thanks.
Perfect. Thanks, Dr. Bradke. So I'll go quickly here. Case 3 involves a 77-year-old gentleman. He presented in the emergency department with a chief complaint of global weakness and overall malaise. He'd been febrile at home. He was a retired radiologist. I don't have control of the slides.
Just say next slide then.
Okay. So he was a retired radiologist, and he got to the point at home over a course of 3 days that he was unable to ambulate, and overall he was a normal functioning gentleman prior to this. And so on exam in the emergency department, he was febrile, tachycardic, bilateral upper extremities. He had weakness in his deltoids, 3 to 5, 4 to 5, and all other myotomes. Sensation was intact. Lower extremities, kind of the same story, with gross weakness, and bilateral lower extremities. He had sustained clonus, otherwise was normal reflexive. So laboratory work, next slide. demonstrated a white count of 11, CRP of 42, ESR of 36, and his blood cultures were positive for MSSA bacteremia, as well as from urine. Given the concern as well as his neurologic dysfunction, got an MRI. Next slide. There's a couple of representative sagittal images showing a large retropharyngeal abscess, as well as a ventral phlegmon extending from about C3 down to T2. Next slide. This representative images at 3-4. As you can see, you have, again, that large retropharyngeal abscess anteriorly, a ventral phlegmon. Next slide. At 4-5, you can see you have a component of osteodiscitis with destruction or starting of the C5 vertebral body. Next slide. At C5-6, you can see again that ventral abscess causing pretty severe spinal canal narrowing. Next slide. And so with an overall diagnosis 4-5, 5-6 osteodiscitis with a large ventral cervical epidural abscess and a large retropharyngeal abscess as well. The discussion at this point in time was obviously this patient, given his neurologic compromise, was going to go to the operating room. And what should we do? Was that to do a multi-level ACDF or a corpectomy with an ACDF hybrid, or finally both an anterior and posterior surgery? Next slide. I think we can move past this as we were convinced that he needed an operation. Next slide. Ultimately, we chose to do a C4 to C6 ACDF. Next slide. As you can see here are intraoperative fluoros showing adequate alignment, preserved disc height. Mostly I'm going to point out. Next slide. So if you look here, here's our 6 weeks post-operative radiograph. At the 6-7 level, you can see that we have preserved disc height as well as at the 6 vertebral body. However, if we follow this patient out and at 6 weeks, he's doing incredibly well. He's back to his neurologic baseline. He's had complete return of neurologic function. He's an agent E. Next. But if we continue to follow him out for 6 months, you can see that he has significant vertebral body collapse at C6 with adjacent segment at C6, C7. And so obviously our concern at this point in time was that he had recurrent infection. However, a recurrent workup showed no signs of infection. We had an MRI that showed no gross signs of infection as well. His laboratory work was normal. And like I said, he was doing very well, no significant pain or neurologic compromise. And at this point in time, he was back to skiing. And so we followed him for the next 6 months. Next slide. He's now 1 year post-op. He really hasn't changed much from that initial vertebral body collapse that we saw between 6 weeks and 6 months. Like I said, he's back to skiing 50 days a week. And he's having a full neurologic recovery. So the discussion, I guess, really is when you see that at the 6 month time period, should we have intervened or continue to follow him like we did?
Well, you're back to what everybody deals with in their practice every day. Do you treat the x-rays or treat the patient?
Yeah, if we hadn't seen the x-rays, we thought your case went swimmingly.
Yeah, the X-rays are very concerning. The retropharyngeal space is still a little bit wide. It's concerning. And even in a patient that's doing great, you got to lay the crepe.
Sig, can I ask you a question? Thoughts on use of allograft versus metal versus autograft in an infected ACDF? Or in a patient you're going to be treating, not the ACDF is infected, but you're going to do an ACDF after you treat the.
Yeah, really important question, Daryl. Thanks for asking that. I think many of you are familiar with the work that Coy Chan did, and some of it with our group here at UCSF, some of it up in Oregon, and Coy looked at peak. And I think somebody made this comment in chat as well, suggesting that really the non-union rate with peak antibodies was poor. And certainly for infection, I'd be very reluctant to use peak. My preference in these cases is actually to use autograft. Having said that, in a number of thoracic cases and more complex cases that involve a big reconstruction, we have used titanium cages. So the titanium cage, I'm not opposed to here, even in the cervical spine. I think that we wrote a paper with Jürgen Harms some years ago now, about 15 years ago, suggesting that recurrence of infection was actually quite rare with titanium reconstructions, including cages. So I think the titanium cages were a reasonable idea. My preference tends to be autograft or allograft in these cases.
Hey, Sig or Daryl, what about in addition to, obviously, in the face of infection, post-op imaging? I would think the post-op imaging would be much more obscured using a metal cage and a metal plate, as opposed to, like you said, allograft or autograft.
Yeah, thanks, Scott. I agree with you. I mean, it's really important, and a lot of people have been asking about MRI post-operatively, and we commonly will be reevaluating these patients to see how they're doing. And yes, with contrast, there was another question about that. Some metal cages are much harder to see around than others. Some of these newer 3D printed titanium cages actually aren't bad to see around on MRI, so don't create near the signature that the older ones did, but certainly more than an allograft or autograft piece. So I think your question is a good one. I'm okay with either. We use titanium, we use allograft. We don't usually use autograft, and we never use PEEK. Neil, any thoughts from you? Okay. Oh, you're muted. Sorry.
Sorry, I always use allograft. Go to
only allograft. Yeah.
Allograft for infections in the disc space.
How about managing this film at 6 months?
I just watch. Purely treating on symptoms, like Scott said, just based on symptoms.
I will tell you though, Neil, and the rest of the panelists, depending on the type, like this is a different type of infection. We've revised a fair number of artificial discs that have had osteolysis secondary to C. acnes infections. And in those, I don't have any qualm about using a titanium coated PEEK cage. It's a much lower virulent type infection, and they seem to heal and do well. But in the face of a staph infection, I agree with Neil. I'd probably use allograft.
Rick Sasso, current president of Cervical Spine Research Society.
Daryl,
comments on cervical spine infections.
Oh, I completely agree with you in regards to the graft. Allograft, never autograft and never PEEK. I think I would like to make one comment. In that second case, it was treated non-operatively. I think that for epidural abscess, conservative treatment is surgical treatment, and the radical treatment is a non-operative treatment. And I think it's important that if you are going to treat them non-operatively, boy, you got to watch them. You got to watch them super carefully. And when they go bad really fast. And unfortunately, I've seen that happen.
That's the second time this week I've been called radical.
Yeah, Rick Sasso, I don't disagree, but if there's ever a case you could try non-operative treatment, it would be that one. And I think it's one of those things. It's an equipoise, as Alex Beccaro says. It's one you could make a good argument either way. And if it was you, would you want the smaller operation and not worry about it, or would you rather not be intubated and turn prone while one of your buddies mucked around near your spinal cord if you're going to get better on antibiotics? So I think you can make a case either way.
I would have had the conservative treatment, which is surgery.
Yeah, I agree with Rick, and Jens said the same thing. I mean, a small little laminotomy, a very low morbid operation, and you could sleep at night.
Yeah, exactly. and that was so far posteriorly, it was like just pluck it out. So I agree with Rick too.
I understand.
Yeah, for all of you folks who we couldn't trust to watch, we would definitely operate on you. So don't worry.
Exactly.
Hey, Daryl, this was great. I think we made so many wonderful points about cervical epidural abscess. It was perfect. It was just great. We started this series for fellow education while everybody was kind of sitting on their hands, but it turned out that we're having the best time. Better than
really
are. Yeah.
I agree.
Absolutely, Jack. Thank you so much for letting us participate.
Thank you, guys. And thanks to SSF. Great job.
Yes, thank you, guys.
Thank you, guys.
Good night, everybody.
Really well done.
Everybody.
Thanks for watching. Hit the subscribe button for more medical content.